Praveen sir, Dr. Chinmoyee ma'am has joined. Please make her co-host.
Yes, it is done.
Yes, thank you, sir. Good afternoon, everyone. We'll start the session shortly. Praveen sir, Dr. Veena ma'am has joined. Good afternoon, ma'am. We'll start in 2 minutes. Requesting all the participants to kindly bear with us. We'll start soon. Praveen sir, can we please start the recording? Good afternoon, everyone. iTech India welcomes all the participants for today's special National Distance Learning Seminar session. Today's topic is revised guidance on tuberculosis preventive therapy, that is TPT, for PLHIV under NACP. We have with us today Dr. Chinmoyee Das ma'am, Head CST NACO, Dr. Veena Dhawan ma'am, Additional Commissioner CTD and CVAC, Dr. Sanjay Mattoo sir, Joint Commissioner and Additional DDG TB CTD, and Dr. Reshu Agarwal ma'am, Technical Lead HIV, Hepatitis and STI, Care and Treatment WHO. We welcome you all for today's session. I now request Dr. Chinmoyee ma'am for the opening remarks.
Thank you. Am I audible?
Yes, ma'am.
Thank you very much. So at the outset, very good afternoon to all the participants, and I welcome Dr. Veena Dhawan and Dr. Mattoo and Dr. Reshu, who are going to be my co-speakers for this session. So this topic of telling all of you about what are the revised guidance on TB preventive therapy for PLHIV under NACP. This has been very carefully thought of, and we had issued a guidance in May. And after that, we did receive a lot of queries from the field. So we wanted to appraise you and to try to resolve all your queries regarding this TPT revised guidance. So we thought that this is a very good opportunity, good platform to also have our central TB division along with us to guide you all. So we understand we have all the ART centers, the ART center staff who have joined us along with the State AIDS Control Society staff. I hope that we also have some state TB officers who are there. That would be really nice. So the reason why we are doing this is to take you through why we revised the guidance on TPT, who should be given what type of regimen, when to start, when to stop, how to monitor, and how will you report. So this is the crux of the presentation that will be done. We want to stress on the fact that all the ART center staff who are providing TPT, if you are not aware, if you think that you need more guidance, please first refer to the guidance note that has been issued, and please write. Anytime you can write and reach out to us regarding any issue you face in giving TPT to your patients. So as you all are aware, this is a new regimen, 1 HP, which is a shorter regimen, which is construed as a more effective regimen. And we hope that the compliance or adherence to this regimen will be better. So to talk on this regimen, we have Dr. Veena Dhawan and Dr. Mattoo who have kindly agreed to join the session. So we, for all the ART center staff, I'd like to stress that please prepare your requirement. Please put the indent well ahead in time. Please coordinate with your state TB officer and district TB officer. And here I'll reiterate that all the State AIDS Control Society officers who are here, please make sure that you are in constant coordination with the state TB officer regarding the availability and other issues related to TPT delivery within the ART centers. So we want that all of you closely monitor because it's a new regimen that we have started, and make sure that you are entering the data at all the monitoring formats which you have, and you report them at the right time, because all these mean a lot whenever we are trying to ensure a newer regimen is in place. So with this, I welcome our CTD officers and also Dr. Reshu Agarwal, who will take us through a detailed guidance. So I hope you all listen carefully and please ask as many queries as you have regarding this topic, because you'll never get a platform like this where you have so many experts giving you guidance. Thank you, Shweta, over to you.
Thank you so much, ma'am. I now request Dr. Veena, ma'am, from the Central TB Division and CVAC for the opening remarks.
Ma'am, we can't hear you. Veena, ma'am.
Veena, ma'am.
Ma'am, you're not audible. Am I the only one?
No, no, ma'am, we are not getting the audio. Veena, ma'am, can you mute and then unmute again? Can you please try? Dr. Veena, ma'am, can you please unmute?
Yes. Can you hear me now?
Yes, yes. Thank you so much, ma'am. Yes, we can hear you, ma'am.
I had to change the room because there was some problem with my this thing. So hello to everybody. Hello to Dr. Chinmoyee, Dr. Mattoo, Dr. Pawar, and I believe all the SACS officer and the ART center staff have joined the meeting. I welcome you all, and I'm really grateful to the NACO division for taking up the new regimen and issuing necessary guidelines to all the states. So basically, as you know, that all the people who are living with HIV, they are at a higher risk of developing TB. So earlier, what we were giving was 9H. That was a long treatment for a period of 9 months, and now we have 1HP, wherein you have to give this treatment only for a period of 1 month or a period of 28 days. So as Dr. Chinmoyee mentioned, that the compliance would be better, it will be easier to follow up, and it is non-inferior to the 9H treatment that we were giving earlier. We've already issued the necessary guidelines. 1HP is already available in most of the states, and more is we are confirming that there would not be any shortage of any drug. We have already supplied, the new supplies have come in, and they have already started moving to the states. So I would just request that today's meeting is very critical. We've already issued guidelines that all people about 13 years of age can be started with 1HP for a period of 28 days. And there are clear guidelines what is to be done for other groups who are PLHIVs. So clear guidance is there. So I would request, as Dr. Chinmoyee already mentioned, that you have to ensure that you are raising the indent to the district TB officer. We have already told them that they need to ensure that enough medicine is available for all the PLHIVs. So please ensure that in case of any further guidance, we are here to guide you continuously, and today's meeting will be here with you to answer any queries that you have. And further, our TTOs have already been directed, and the state immunization or state TB officers have been directed to continuously support the NACO program for ensuring preventive treatment for all the PLHIVs. So that's all from my side, and thank you for NACO for asking us to join this meeting, and we'll be here to support you. That's all from my side. Thank you.
Thank you so much, ma'am. I now request Dr. Sanjay Mattoo, sir, from the Central TB Division for his opening remarks.
Thank you. Actually, I think our video is not working. I am joining from Dr. Radha's point, and it's working now. Okay. So thank you, Dr. Chinmoyee Das, Dr. Veena Dhawan ma'am, and NACP team, and TEP team, and 250 plus participants who have joined through virtual points. A very warm good morning and good afternoon from Central TV Division. At the outset, I would like to congratulate the NACP team to have this very important and very critical meeting. And I would like to thank all the participants who have joined virtually this meeting. So already the important key points about this meeting has been highlighted by Dr. Das and Dr. Veena ma'am. Basically, this revised guidelines, we already understand that many good points are associated with this. This is a TB preventive treatment, which is to be given to the PLHIV. It is of the shorter duration. When we are saying the shorter duration, definitely it is going to decrease the pill burden also. And so chances of adherence and completion of the TPT becomes more better. And that is how we are expecting that definitely once the treatment completion is there, adherence is better, then outcome in the beneficiary definitely is going to better. So this will be advantage of this regimen. And when we are having this implementers part, so in that also it will give the benefit because we know that for the lesser time you will be monitoring those things, supply chain issues also will be resolved sooner. So this is going to be a very good initiative, and I would like to congratulate once again to the NACP to get this particular TPT regimen approved through the TRG, and now we are at the implementation stage. So this is very good progress which has been done. I would also like to congratulate Dr. Reshu Agarwal, who has been assisted and will be taking the technical session further. My best wishes are there for both the audience and the facilitators to have the very good, fruitful, and successful session. But I would request, which has already been said by Dr. Das, that all the participants, please ask as many as you can ask the question, so that there should be no doubts in your mind. All the points need to be clarified so that at the field level there should be no challenges and no difficulty. So thank you once again, and I welcome you all, and best wishes are there from my side. Thank you very much.
Thank you, sir. I now request Dr. Reshu Agarwal ma'am from WHO to please start the session.
Thank you, Shweta, and thank you so much, Dr. Chinmoyee, Dr. Veena, and Dr. Mattoo. I think you people have already set the context, so I'll not get into the details, and I'll just move into the technical part of the session directly. But before I start, I just want to thank all the ART centers who have sent their queries in advance so that the session could be planned and the queries could be addressed. So thanks very much for that piece. And if still you have like queries, please keep posting them in the chat box. And at the end also, we'll try to address your queries. So in this session, I would be discussing about, like, you all know, but then there are some new people who have joined the ART clinic. So why we are talking about the TB preventive treatment. Then who should be offered TB preventive treatment at the ART centers? When to start? What TPT regimens are to be used as per the national recommendations? How do you monitor the patients who are started on TPT, and how do you report? So talking about why TPT. So you all know that what is TPT, or the tuberculosis preventive treatment. It consists of the course of one or more anti-TB drugs, which are given with the intention of preventing the development of TB disease. And usually these are given to the patients or the people who are infected with TB bacteria, or who have been exposed, or those who are at a higher risk of getting TB disease than the general population. Now, TPT is considered as one of the most critical public health approach and is a key intervention for eliminating TB or reaching the end-TB targets. Why TPT is so critical when we talk about PLHIV? So obviously, as I said in my previous slide, that TPT is given to the people who are at a higher risk of developing TB. And now when we talk about PLHIV are at nearly 16 to 21 times higher risk of developing TB disease or having active TB than those without the infection. And the data shows that it is it is very high impact intervention through which we can actually reduce the incidence of TB as well as mortality. So there is enough evidence to show that with TPT, the incidence or the morbidity related to TB reduces to up to 90%. And then the main or the major trial which was done, the Temprano trial, which actually led to the introduction of TPT for PLHIV, definitely showed that there is almost 37% reduction in TB-related mortality if it is given to the PLHIV. And these were the evidence which actually led to the introduction of TPT in the national program. Now, talking about how TPT works. TPT is actually intended to eliminate the TB bacteria. And it usually boosts the IFN or the interferon alpha response to a number of TB antigens, and that's why it reduces the activity of the TB bacteria. It also has a bactericidal activity, and it helps in inhibiting the synthesis of the mycolic acids and the key cell walls constituents, and not actually helping in the replicating of the bacilli. Then some of the drugs also have they support the acceleration of the sterilizing activity and does help in shortening the TB duration of the TB regimen, and that's what we are discussing today. But then something which is very critical about TPT, that it is only to be given when there is no evidence of active TB or the TB disease. So this piece is very critical for all of you to understand. That it's very critical to rule out active TB in PLHIV before initiating TPT. Coming to the historical background, TPT is not something which is new. It is being discussed since 1965. And in the national program, we adopted TPT in 2016, where we started with a 6-month regimen of isoniazid. But I think with time, the things have evolved, and we have more safer, more simpler, and shorter regimen. And we have 1-month regimen now available with us, which we would be discussing in more detail. The other piece, because as I told you that we started TPT or the IPT rollout in country in 2016, and we really wanted to see what is really happening with the PLHIV who were given IPT in the early phase. And in this regard, ICMR did a very nice study, which is a multi-centered prospective study. And what they found that there were 89% completion rate, 3% discontinuation because of the adverse events, and the incidence of post-TB really reduced to 0.64 per 100 person year. So this is really very reassuring. Now coming to the question that who should be offered TPT? So we have a quiz here. Praveen, can you please display the quiz? So the question is, who should not be offered TPT? Children living with HIV who are less than 10 years, children less than 12 months of age, who are in contact with a TB patient, pregnant and breastfeeding women living with HIV, PLHIV who have CD4 count less than 200, or none of the above.
Requesting all the participants to please attempt the e-poll. You can click the answers on your screen.
We'll close the poll in 1 minute, Shweta.
Yes, ma'am. We have the timer set.
Sure.
Ending the e-poll now. Ma'am, results are on the screen.
Thank you everyone for giving your answers. So I think we really got a lot of mixed answer that who should not be offered TPT. So the correct answer is actually none of the above, and we will discuss this in more detail now. So talking about who should be offered TPT, all adults and adolescent PLHIV who are more than 10 years of age should be offered TPT. Children aged more than 12 months should be offered TPT. Infants less than 12 months who are in contact of a TB patient or those who are born to a TB positive mother should be offered TPT. And additionally, the children who have successfully completed treatment for TB disease should be offered TPT as secondary prophylaxis. But something very critical to be mindful of is that TPT has to be offered after ruling out of TB disease. And it has to be offered regardless of the ART, what kind of ART patient is taking, pregnancy, previous TB treatment, the immunosuppression or the CD4 counts of the patient, and availability of the test for TB infection. So these things don't matter. It has to be given to all PLHIV who are more than 12 months of age. So all children and all adults and adolescents living with HIV should be offered TPT, and infants who are less than 12 months, if they are in contact of a TB patient, then they should be offered TPT. We have another quiz here. A test for TB infection is not a requirement for initiating TPT among PLHIV. Is it true or false? Can we have the poll?
Yes, ma'am. Ending e-poll now.
So I thought I'll get the right answer for this question at least. You all have been doing TPT for such a long time. Do we do a TB infection test? So how do we rule out TB among PLHIV at ART centers? So for adult and adolescent, all PLHIV should be screened for current cough, fever, weight loss, and night sweat. And if they don't have any of these symptoms, they are then unlikely to have TB disease and should be offered TPT. Similarly, for children more than 12 months of age who do not report any poor weight gain, fever, current cough, or history of contact with a TB case, they are unlikely to have active TB and they should be offered TPT. Infants who are less than 12 months of age, if they are in a contact of a TB person, then they should be properly evaluated for TB by an expert, and it's always good to refer the infants to a pediatrician for a proper evaluation. And if they don't have any symptoms of TB, then TB preventive therapy has to be offered. And this group, like less than 12 months of age, is very critical because at ART centers, we are actually dealing with the exposed children. So all these infants, those who are born to a positive mother or those who are in contact of TB, and they are already exposed to HIV, they may be reactive to HIV. So for them, the chances of progression to TB are really very high, and the death rate among this group is very, very high. So that's why it's very critical to take care of this group. And This has to be taken care as part of your care of exposed children. So this is the diagrammatic presentation of the same thing which we discussed, that all children more than 12 months of age should be screened. And for adults and adolescents, the 4 symptoms are current cough, fever, weight loss, night sweat. For children more than 12 months, weight loss, fever, current cough, and history of contact with a TB case are the 4 symptoms. And if none of the symptoms are there, then in these cases, we can offer TPT to these PLHIV, but then obviously we really want to understand, like, there should not be any contraindications to TPT, which we would be discussing in the next slide. But if these patients are having any of the 4 symptoms, then they should be properly evaluated for TB. So this becomes very critical, that you refer them for proper evaluation of the TB, or you evaluate them for TB, and if they are found to be TB positive, then they should be put on appropriate treatment. So as I said earlier, that we actually rely on 4 symptom screening, and for PLHIV, though X-ray or TST or IGRA, the other TB infection tests, they may have added advantage, but then as a public health approach, they are not required. And if you do a good 4 symptom screening, then you can be like almost 98% sure that the PLHIV whom you have screened negative will not have TB, and you can safely initiate them on TB preventive therapy. And what we see that for the 4 symptoms, the negative predictive value with 5% TB prevalence is almost 98.5%. So almost 98.5% of the PLHIV who do not have any of the 4 symptoms would be negative for TB, active TB or for TB disease. Now coming to the question, when to start TPT? So what is the optimal timing to initiate TPT among PLHIV? This is a quiz question. So should it be started after 3 months of ART initiation, or when the viral load test result is available, when CD4 count has increased to more than 200 in the patients with advanced HIV disease, after PLHIV have well-tolerated CPT, or we start ART and TPT at the same time?
Ending e-poll now.
So most of you got this answer correct, and I think this was discussed very intensively in the capsular training. So it means that the messages in the capsular training have gone across very well. But still, like, some people are still saying that we should wait for 3 months or till the time CD4 counts improve or CPT is tolerated well. So that is not the case. So why we are talking about initiating TPT and ART at the same time now? Because when you see the combined effect of TPT and ART is actually has a huge impact in reducing the TB incidence. And the various studies have shown that the reduction is to the level of 80 to 97%. And this is because of the restoration of the tuberculosis-specific immunity, and both IPT and ART together, they help in preventing the mortality, the TB incidence as well as mortality. And this piece becomes very critical in PLHIV with advanced HIV disease. So because the PLHIV who are having advanced HIV disease or the CD4 counts less than 200, they are anyways at a higher risk of developing TB disease. So obviously in these PLHIV, we don't want to wait unnecessarily and then let the TB progress into a TB disease. So we really don't want that situation, and that's why the TRG took call that among PLHIV, TPT and ART should be initiated at the same time, but obviously after reliably excluding the active TB. And in case if there is a doubt, if you are not sure, then there is no harm in waiting for some time. But as a general rule, because what we initially advocated was that you have to wait for 3 months. So that 3 months guideline is no more applicable now. You need to start the PLHIV as early as possible, because when you start ART and TPT together, the beneficial effect would be complemented and people would be protected from developing TB disease. So that is the advantage which we have here. And we don't want to unnecessarily wait and deprive PLHIV, especially the PLHIV with advanced disease. We don't want to deprive them of TPT. So please exclude active TB disease. And if the PLHIV don't have TB disease, in that case, you can start ART and TPT together. Now, for some of the ART centers, there are still some of the PLHIV who are already on ART for a long time, but they have never been provided the TPT course. So for these PLHIV, you need to give them or start the TPT course as early as possible. And whenever, like, you have to discuss with your counterparts or the STOs and see that whenever the drugs are available, you need to do a mop-up exercise for all the PLHIV who have not been provided TPT so far. Now, talking about some of the contraindications for TPT, obviously active TB disease is an absolute contraindication and nobody should be providing or giving TPT to the PLHIV who have active TB disease. Then active hepatitis, regular or heavy use of alcohol, signs and symptoms of peripheral neuropathy if isoniazid has to be used. PLHIV who have completed DRTB treatment, concurrent use of other hepatotoxic medications, or if there is a known allergy or hypersensitivity to any of the drugs which would be used as part of the TPT regimen. In those cases, you need to be a bit cautious or see what the definite guidelines say, or you may want to use an alternate regimen. So there were some conditions in the initial guidelines which were like poor adherence to CPT, poor understanding of IPT by guardian, or context of MDR-TB. So these 3 conditions have been removed from the list of contraindications. So we don't get into this piece of like poor adherence or poor understanding by IPT by guardian. So these conditions were very vague and they have been removed. And also for the context of MDR-TB, now there are concrete guidelines that what TPT regimens you can use in such cases. So these conditions have been removed, and because of the adherence issues or poor understanding of TPT only, the program actually decided to go for shorter TPT regimen. So hopefully, like the shorter TPT regimen would be able to answer a lot of issues which you had earlier with the previous regimens. So once like the screening for TB symptoms has been done and the TB disease has been ruled out, in such cases, ART-MO needs to do a proper assessment of the PLHIV for TPT initiation. And obviously, for all the new PLHIV, these assessments are part of the baseline workup. So this is something not new for the ART medical officer. These all are part of your regular history taking, regular workup, which you do for all the PLHIV. So, but especially with the TPT point of view, these are some of the things which you need to like really focus on. One is the personal history. You just take the relevant information which you anyways do. Then the issue of pregnancy or any contraceptive use, assess for the presence of any comorbidities, and does the patient has any substance abuse history or like alcohol, oral or injecting drug use. The history of medications, whether like there are some hepatotoxic medications which are already ongoing for any of the comorbid conditions for this PLHIV, and does the patient has any known allergy or hypersensitivity to any of the drugs which would be considered as part of the TPT. And then LFT, anyways, the liver function test you anyways do for all the PLHIV when they are initiated on ART. But for TPT initiation, this is not a mandatory requirement. But then for the PLHIV who are at risk, like somebody who is having a comorbid condition, Hep C positive or alcoholic, in such cases, you would want to do a baseline LFT before initiating on TPT. And if you have abnormal baseline LFT results, which means that if the ALT or AST is more than 3 times upper limit of the normal upper levels in the presence of symptoms, or more than 5 times the upper normal limit in the absence of symptoms, in that cases, you may want to use clinical judgment, and you may still want to defer also TPT for time being and take a decision at a later stage when the acute condition has subsided. Now coming to what TPT regimen are recommended under NACP for the PLHIV. We have a quiz question here. What is the most preferred TPT regimen for PLHIV more than 13 years under NACP? 1 HP, that means 1 month of INH and rifapentine, 3 months of INH and rifapentine, 6 months of isoniazid or IPT, what you used to call earlier, or 4 months of rifampicin or 6 months of levoflux. Can we have the quiz question?
Yes, ma'am. Ma'am, there's some technical error. Can we please
No
have those
issues. You can
answers?
put it in the chat box, please. So most of you got this answer correct. Obviously, as we are discussing and the guidance which you got, 1 month of isoniazid with rifapentine is the preferred regimen now for PLHIV who are more than 13 years of age. And we will discuss all these regimen in more detail. So this was the OM which was issued in the month of May and sent to all the state AIDS control societies and ART centers. So you would have seen this OM. And based on this OM, for the PLHIV who are more than 13 years of age or older, the preferred regimen is 1 HP or the isoniazid and rifapentine daily, once daily dose for 28 days. And with this, no dose modification of DTG is required. However, for PLHIV who are less than 13 years of age, or for the pregnant and breastfeeding women living with HIV, or the PLHIV who are on a PI-based regimen, for such kind of patients, you would still use INH for 6 months as a daily dose. So this regimen is called 6H. Now, why did the program took this decision of using 1 HP or 1 month of rifapentine and isoniazid for PLHIV? So there were enough evidence to say that in terms of efficacy, these shorter regimen, because obviously the discussion point for the national program was that with 6 months of INH, there were some issues of discontinuation of the treatment interruptions, people not completing IPT, and then there were issues in terms of the pill burden or the doses which patients were required to take. So I think keeping all that in mind, this was deliberated that should we go for shorter TPT regimens in the country or not. And there's enough evidence to show that in terms of efficacy, the 1 HP regimen was almost comparable to the 9H or the 9 months of isoniazid. So there was no head-on comparison between 1 HP and IPT for 6 months, but then there were comparisons between 1 HP and 9 months of isoniazid, and these were found comparable. In fact, for 1 HP, the TB incidence rate was found to be a bit low, and then the completion rates were also similar, and the adverse effects were also comparatively low. Also, so between INH of 6 months and 1 HP, this was mainly the decision point that obviously with 1 HP, we can get the similar kind of results or maybe bit better results with a shorter regimen. The other piece which was deliberated a lot was should the program go for 1 month of daily dose of isoniazid acid and rifampicin, or should we go for the 3 months, which means 12 weekly doses of isoniazid acid and rifampicin. And for this, I think there was again a lot of deliberation, and because we really had a good experience in the program with doing the daily TPT regimen. So that was the point which was in favor of using 1 HP rather than 3 HP. And also the studies showed that the completion rate as well as the efficacy of 1 HP and 3 HP among PLHIV were similar. So these were the main things which actually led to this decision to use shorter regimen in the national program for PLHIV, and which was or which is 1 HP, 1 month of, or 28 days, 28 doses of rifampicin with INH. The other piece which has been newly introduced as part of the TPT regimen is the regimen for PLHIV who have contact with the drug-resistant TB patient. So earlier, this was a contraindication that you shouldn't be giving IPT to these patients. But now, program has come out with very clear guidelines that PLHIV who have a contact with a DRTB case, they should also be offered TPT regimen. And this group becomes, again, all the more important because PLHIV are anyways at a higher risk of getting TB. And if they are in contact of a DRTB case, obviously they would develop a DRTB disease, and we really want to protect them from the DRTB or the MDR-TB. So for such kind of contexts, so PLHIV who have a contact with a TB patient who has INH resistance, but because now for all the patients, you are supposed to do a drug resistance testing or the drug susceptibility testing. So the DRTB case, which has resistance for INH, but is rifampicin susceptible, for these kind of PLHIV, you would use a 4 month of daily rifampicin. For the PLHIV who have a contact with a TB patient who has MDR-TB or the rifampicin-resistant TB, but it is fluoroquinolone susceptible. In those cases, 6 months of daily levoflox has to be used. For DRTB cases, for eliciting the contact of the DRTB case, it is very critical to take a proper history of the index case. Who was the index case? What type of TB, or what was the susceptibility or the resistance pattern of this patient? And then accordingly, you have to decide on the regimen. So these cases would not be very frequent cases, because at the ART centers, we are only talking about PLHIV and not the household context. But if you have a PLHIV who has been, who knows that he has been in contact of a DRTB patient, or if so that is one way of approaching these patients. The other way would be, because in the ART centers, we usually have families or multiple family members from one family being on ART. It could be maybe the spouse or the kids. So we have those kind of permutations. So if you have a diagnosed case of MDR-TB or a DRTB at the ART center, and if you have other PLHIV or the other family members who are also availing ART, so that's where you need to be very vigilant, that you should know that if you are diagnosing any case of DRTB, just look into the other family members of this patient, whether they are also receiving ART from your center, and then these kind of patients should be provided the TPT regimen for PLHIV having contact for DR-resistant TB. So this is the approach you would take for such kind of cases. Either the patient is self-reporting to you that he or she has a contact with a DR-TB case, or you have a DR-TB case and you might want to look into the family members of this DR-TB case, that whether if this case of DRTB has a member who is enrolled with your ART center, and then you should elicit this person for TPT initiation. Now, coming to to the details of the regimen, so when we are talking about 1 HP STPT option, which means 1 month or the 28 days of isoniazid plus rifampicin. For this, the eligibility criteria is more than 13 years. Duration is 28 days, total course is 28 days, daily dose is to be given. And for drug interactions, it is contraindicated with the protease inhibitors. And with DTG or TDF, you don't require any dose adjustments. Usually, the adverse effects would be petotoxicity or hypersensitivity reaction, gas, or GI upset. And then in terms of absorption, the peak absorption increases when given with the meal. So based on this kind of a profile of this drug, the PLHIV who are eligible for this regimen or for 1 HP are the PLHIV who are more than 13 years of age, and we need not give it to the pregnant women or the PLHIV who are on PI-based regimen. So these are just the two exclusions. So all PLHIV more than 13 years can receive 1 HP. But if there is somebody who is pregnant or on a PI-based regimen, so these are two exclusion criteria for this regimen. Coming to the dosage. For this, the dose for rifampicin is 600 milligram and isoniazid is 300 milligram. So usually this you will get in terms of different permutation combinations. So there is a FDC which is available, and this FDC has 300 milligram of rifampicin and 300 milligram of isoniazid. So if you have this FDC, and then this has to be clubbed with 300 milligram tablet of rifampicin. And that's how when you do this, you will give patient 2 pills daily for 1 HP dosage. If you have the FDC dose of 300 plus 300, and if you have rifampicin of 150 milligram, in that case, you will take 1 tablet of FDC and then 2 tablets of rifampicin 150 milligram, and the total pill burden would be 3 pills here. In case if you don't have FDC, you might have rifampicin 300 milligram, isoniazid 300 milligram. So what you need to do is rifampicin 300 milligram, 2 tablets plus INH 300 milligram, 1 tablet, and the pill burden here again would be 3 tablets. And in case if you have rifampicin 150 milligram, in that case, you will have to use 4 tablets of rifampicin and 1 tablet of isoniazid 300 milligram. And in this case, the pill burden would be 5 pills. So it would depend on the kind of supplies you would be getting from your counterparts from the state TB offices in the state, and based on that, you will have to prescribe. So for the ART medical officers, I just want to sound a word of caution here. Please just don't write the regimen here. Please be specific that what you are prescribing, what stocks do you have, which tablets do you have? Do you have FTC, or do you have 300 milligram, or do you have rifampicin 150 milligram? Based on that, please prescribe very clearly. And for the pharmacist, it's very important to please highlight this, as well as for the counselors to highlight this to your patients, that how many pills are to be taken ultimately. And this, because the supplies are being streamlined now, so you might have different combinations coming in. So please be mindful of what supply you have and how many pills a patient has to take as part of 1 dose. Coming to 6 sachets treatment option. So this is 6 months of INH, which you were anyways using till now. So there's nothing new, and the doses is total 180 doses. There are no interactions with ART, no contraindication for pregnancy, and it is best absorbed when given empty stomach. So based on this profiles, all PLHIV who are less than 13 years of age should be getting 6 months of INH. Pregnant and breastfeeding women would also get 6 months of INH, and the PLHIV who are on PI-based regimen would also get 6 months of INH. Coming to the dosages, so you are anyways well versed. For the adults, it's 300 milligram, and for the children less than 12 months, it's 10 milligram per kg body weight. And you have this chart which you can put on your table as a ready reckoner. Pyridoxine is preferred to be given when you are giving INH, but then non-availability should not be a barrier to provide or prescribe INH. And you can even use from your hospital supplies, whatever multivitamins or B complex medications you have, which have pyridoxine, those can be prescribed to the patients. Coming to 4-HRS treatment option. Now this means 4 months of rifampicin, which means 120 doses, and daily dose needs to be given. No safety or efficacy data for pregnancy is available for this. And 4R is actually contraindicated with PI. No dose adjustment is required with DTG. And with DTG, dose adjustment is required. And for TDF, no dose adjustment is required. So for the eligibility criteria for the PLHIV would be the PLHIV who have a contact with the INH resistant but rifampicin susceptible TB case. And it is not to be given to the patients who are on PI-based regimen. And as you know, as we do with the ATT, when you give a rifampicin-based ATT to the PLHIV, you increase the dose of DTG from 50 milligram to 100 milligram daily. So you give an additional 50 milligram. And that's what you need to do in this regimen also. So if you are starting any PLHIV who is on TLD on this regimen, a 50 milligram additional dose needs to be given. And the dosage is for adults more than 10 years, for more than 10 years is 10 milligram per kg per day. For age less than 10 years, it's 15 milligram. And the highest dose which can be given is 600 milligram. Coming to Levoflox, 6 months of Levoflox. So this is again once daily dose. It's safe for pregnant women and no known interactions with the ART as of now. And it has to be given to the PLHIV who have a contact with MDR-TB patient who is rifampicin resistant but fluoroquinolone sensitive. Sorry, it can there's a typo error. It can be given to the PLHIV who are on a PI-based regimen. And here you have the dosage, which you can use as you can take a printout of this and use as a ready reckoner. So coming to the details about TPT initiation, monitoring, and outcomes. So for initiation of TPT, obviously you need to first rule out active TB or the TB disease. Appropriate TPT regimen, as we discussed in the last slides, you need to find out what is the appropriate TPT regimen for this patient, and accordingly you have to prescribe this. Counseling needs to be done for all the PLHIV who are initiated on TPT, for the need of TPT, why they are being prescribed TPT, what is the schedule of medication, what is the pill burden, when they need to take, and when the follow-up needs to be done, or any adverse effect. It's always advisable to tell your patients that they should report back at the earliest in case if they develop any adverse effect. And the most common adverse effect is if they have a persistent nausea or loss of appetite for more than 1 day, they should be coming back to you so that you can evaluate them for liver function tests. Also, because now we are saying that we can start we can start TPT along with ART, and there would always be a risk of occult TB or subclinical TB coming to surface. So that could happen in some cases. So please tell the patients if they have any new onset of the symptoms or if they have any worsening of the symptoms, they should be coming back to you. And if the patients are started on 1 HP, then the 28 doses should be given at one stretch. If the PLHIV are started on other regimen, then 1 month dosages can be given and they should be requested for monthly follow-ups. But with IPT, I think we really had a good experience of even doing the multi-month dispensation after 3 months of monthly dispensation. So those practices can still be restored. Coming to the monitoring piece, so whenever the patient is coming back to you, please do the 4 symptom screening and adverse effect monitoring. It is very critical. In case the patient develops any signs and symptoms related to TB, in such cases, you should evaluate the patient for TB disease. And if person is found TB positive, then the TPT should be stopped immediately and appropriate ATT needs to be initiated based on the drug susceptibility testing of the patient. And any decision to modify, stop TPT needs to be taken by the ARTMs. Now, coming to the definition of treatment completion, what is treatment completion? So overall, the principle of defining treatment completion is that the patient should have completed 80% of the doses of the given regimen. Whatever regimen you are providing, the person should have taken 80% of the doses of that regimen within additional 33% of the time. So suppose if you are giving 1 HP, so that means person should have taken more than 23%, 23 doses, 23 out of 28 doses, and within, because the actual duration of the treatment is 28 days, but here you get a buffer, and the actual time comes out to be 37 days, but just to round it off. So if within 40 days, patient has taken more than 23 doses, we define this as treatment completion. For 6H, 144 doses should have been taken within the maximum duration of 239 days. That means 6 months plus 33% buffer time. Similarly, for 6 months of levofloxacin, the same criteria, 144 doses out of 180 within 239 days. And for 4R, the total doses should be at least, because the recommended dose is 120. So out of this 120, 96 doses should have been taken in a maximum period of 160 days. So this is how the treatment completion is defined. Now, how do you manage the missed doses? So I think with 1 HP, with IPT, you all are aware that how we used to manage the different scenarios. So now your major regimen would be 1 HP. And for 1 HP, if firstly, you have to see whether the patient has missed the doses for more than 1 week or less than 1 week, or like 7 days or more than 7 days or less than 7 days. So if the duration of interruption is less than 1 week and patient has already taken more than 80% of the doses, which means more than 23 out of 28 doses, you don't have to do anything, just complete the remaining doses. If the patient has taken less than 80% doses, that means less than 23 out of 28 doses. In this condition, you resume the TPT treatment immediately and you try to complete the treatment within maximum 6 weeks of the first dose. Now, if the treatment interruption is for more than 1 week, in such cases, if the patient has missed intermittent doses, no, not continuously, if the 7 doses have been missed intermittently, in such cases, you can resume the TPT immediately and add the missed doses to the patient's treatment, and the treatment should be completed within the maximum duration of 8 weeks. If the patient has missed 7 consecutive doses, in those cases, you need to consider restarting the entire treatment again. And if adherence to 1 HP is not possible because of the adverse effect or some issues, then you need to consider alternate regimen. And I know this is a bit complicated to understand. So to begin with, I would encourage again that you take a printout of this and please keep it as a ready reckoner. And whenever you people are used to doing the pill counts for ART, in the similar way, you have to do the pill counts or ask the patient for number of pills taken and calculate the adherence. And if there are these scenarios coming up, then you can even look into these scenarios and take the decision that what needs to be done. So, but once you start doing it, it would be easy. Similarly, for 6 months of INH or 6 months of levoflox or 6 months of or 4 months of rifampicin, you need to first take a decision whether the patient has missed the doses for less than 2 weeks or more than 2 weeks. If it is less than 2 weeks, then you resume the TPT whenever the patient is coming back to you, and you add the number of missed doses to the patient's treatment, and no need to change the schedule of the patient's visit. They can come as per the schedule, and the remaining doses can be actually adjusted in the last. But if the patient has missed the doses for more than 2 weeks, in those cases, if the treatment interruption occurred after a patient had taken more than 80% of the doses, then you can continue and complete the treatment. So if you are getting this 80%, the golden rule is you don't have to do anything. You have to just continue with the treatment and add the remaining doses. If the patient had taken less than 80% of the expected doses, and the treatment can still be completed within the expected duration, that means 133% of the time, the duration of the regimen plus 33% additional time, then you can continue and complete. But if the treatment, if the patient has taken less than 80% of the doses and treatment cannot be completed within the treatment duration plus 33% of the additional time, in that case, you will have to consider for restarting the course. These are the possible adverse effects of some of the TPT drugs, and because you already manage the patients on ATT, so you all know that which are these adverse effects. I'll not get into the details. And in terms of management, if you have adverse effects which are very severe, then you need to immediately discontinue. But if there are mild to moderate side effects, then conservative management should be done and you can continue under observations. Coming to the special situations now. So what do you do if the patient has a liver disease and TPT? So obviously we know isoniazid and rifamycins may have hepatotoxicity. They may be associated with hepatotoxicity. So if as I said in the earlier slide, if the baseline ALT or AST is more than 3 times of the upper normal limit with the presence of symptoms, or more than 5 times without the symptoms, you can consider to defer TPT unless the condition resolves. And the same would apply for the conditions of acute hepatitis, including the viral hepatitis. So if you're getting patients with Hep B, Hep C, who are in the acute condition and have deranged ALT or AST, in such cases, you can defer TPT unless the condition has resolved. For patients who are, or the PLHIV who have HCV co-infections, so rifamycin and including rifapentine can actually decrease the concentration of the Hep C drugs, and they can bring them down to the subtherapeutic levels. So basically rifamycin, which means rifapentine containing regimen or 4R, is not recommended with the HCV drugs. And in such cases, what you can do is you can defer the TPT treatment till the patient completes the HCV treatment. And usually the HCV treatments are 12 weeks of treatment, so there is no harm in waiting for the 3 weeks. And anyways, because you're treating the patient with ART, HCV, so once the HCV treatment is stopped, after that you can start TPT. For the patients who have chronic HBV co-infection, in those cases, both 6H, 6 months of INH, or 1 month of rifapentine and with INH are well tolerated and you can give them. Coming to the impaired renal function with and can we give TPT? So usually isoniazid and rifamycins, they are eliminated by biliary excretion. So thus no dose adjustments are required if the patient is having an impaired renal function. With pregnancy, TPT is not a contraindication during pregnancy. Both INH and rifampicin are safe to be considered during pregnancy, and they can be started during antenatal period or postnatal period. It's always advisable to give pyridoxine during pregnancy. And for rifapentine, there is very limited data available on the efficacy or safety. So 1 HP is not recommended during pregnancy. So in terms of the regimen which we have, you can safely use INH during pregnancy. If the person is on taking contraception, oral or injectable contraceptives, which are hormonal in nature, so there is the risk of decreased contraceptive efficacy, and patients should be this history should be evaluated, and they should be told to use alternative mechanisms. And if the women are using the contraceptive implants, in those cases, the replacement might be required a bit earlier. So rather than 12 weeks, you could go for a replacement at 8 weeks. Babies born to the mother who have TB disease, this we already discussed, that if there is a newborn, so obviously this newborn would be HIV exposed, and now he is also TB exposed. So obviously you want to, as part of your care of exposed child, you want to refer these kids or infants to a specialist or a pediatrician for proper evaluation and excluding TB. And if there are no signs and symptoms of TB, in those cases, these kids can be given 6 months of INH with pyridoxine. Coming to the use of TPT in PLHIV who are using drugs. Now, rifapentine has not been systematically studied in people who use drugs, but we know that rifampicin is known to reduce the exposure of the OST, such as methadone and buprenorphine. So in such cases, whenever you are starting these patients on 1 HP or 4HR, please monitor the patients for the signs of opiate withdrawal or any adverse effects. And you might want, these patients might need a dose adjustment or the increase in the dosages for their OST treatment. So whenever you are like actually dealing with the PLHIV who are into injecting drug use, and when you are starting them on TPT, it's always to involve the OST doctor as well in this, and just tell them, because for the OST, these people would be coming daily for their OST pill pickup or for the OST dosages. So please inform the OST doctor about the TPT regimen and tell that doctor that they need to monitor for the withdrawal symptoms and might have to increase the dosage of the OST. 6H is safe to use, but then because the issue with the injecting drug users is basically the adherence to the long-term treatment. So ideally, one would prefer 1HP over 6H in the people who inject drug. But then please do work with the OST medical officers and have a proper plan for such kind of patients, so that, and it's just a matter of 1 month. So within 1 month, these adjustments would be required. And once the patient is off the TPT, then obviously the normal or the routine dosages can be started again. Coming to recording and reporting. So for IPT, anyways, you all know that you were doing the reporting in the green book. You were doing the reporting in the white cards, and these are the sections of the white card. So the similar way, the way you were doing the reporting for the IPT, you would continue to do the reporting for TPT now, but the only thing is you will have to mention that what regimen you are starting the patient, and whether the follow-ups would be like based on the regimen you are starting. So if it is 1 month, the regimen patient would be coming back to you after a month for 1 HP, 6H or levoflox, it would be still 6 months, and for rifampicin, it would be 4 months. So you have to see, do the follow-ups accordingly, and those have to be documented in the white card and then reported in the SOCH as well. So some of the action points in terms of implementation now. So this is something which was sent to you in the OM, and perhaps you all would have already started working on this. So you need to, for especially for the SACs and the ART centers, you need to calculate the quantity of the various TPT regimen you require. And now you have very clear indication that what regimen are to be used in which type of patients. So you need to estimate the total number of patients in each category, and how many courses for each patient, for each category of patients you would be requiring. And what is the available stock of TPT you already have. You might still have IPT available. Also, if somebody is on IPT currently or on 6 months of INH, in those cases, you don't have to change the regimen. Please continue with the same treatment and let the patient complete 6 months of INH. And once that is complete, it's fine. So there is no need to do any shuffling or reshuffling of the patients between the regimen if they are already on INH for 6 months. Annual intents needs to be prepared. Then, as it was initiated as was stated in the initial remarks by CTD as well as NACO, you need to really work in very close collaboration with your state TB officers and with your district TB officers to give them the proper intent or the proper requirement you would be needing for the TPT regimens. And I know Central TB Division has already issued the memorandum in terms of releasing the stocks for 1 HP to the state. So the drugs would have arrived to your state. So please work with the state TB officers and the district TB officers, and whatever stocks are available, based on that, you start using these newer regimens for your PLHIV. But please ensure that whenever you are starting any patient, you should keep the quantity for the entire course reserved with you. So if you're starting somebody on 1 HP, anyways, for 1 HP, it's one-time dispensation. So, but there should not be any disruption. So if you are starting somebody on 6 months of INH, please keep the 6 months stock in reserve for that patient and don't start too many patients. So if you have stock for 100 patients, you start only 100 patients, not 200 patients, and give them drugs for 3 months. So this is very critical. Please discuss with your STOs and TTOs, like what kind of supplies you are getting, and you might have to plan for a phased implementation. So for suppose for 1 HP, if you are getting like maybe for 10% of your PLHIV, you may want to initially prioritize a new PLHIV, and as and when you get more stocks, you can complete all the backlogs which you have at your center. So that's how you have to work on this. I think NACO also developed a very simple template on doing specifying the patients in each category who would be requiring TPT. They could share that template as well, so that you have a uniformity in doing the forecast requirement for all the TPT regimen. With this, I would end this session, and if there are questions, concerns, we can open for that.
Thank you so much, ma'am. I'll just share my screen. We have few questions in the chat box. Ma'am, you want me to read the questions?
Your screen is not shared, Shweta.
Yeah. Give me a minute, ma'am. Ma'am, is the screen visible?
Yes, it is visible.
So is pyridoxine needed with 1 HP? This, I think I already stated that it's always advisable to give pyridoxine if it is available, but non-availability should not be a barrier to start. And you can even use a multivitamin or a B complex formulation, which is available in your health systems, in your hospitals with pyridoxine. Children below 13 years can't be given 1 HP. Then what is to be given? So they need to be given 6 months of INH, 6 months of isoniazid regimen, what you were using earlier. Are the patients with past history of ATT eligible for TPT? So when a patient is like being newly registered at the ART center, irrespective of the past history, you need to start them on TPT. I think that does answer your question. Can we give 6H to PLHIV on HCV treatment? For HCV treatment, I think I had a detailed discussion. Because even INH has it may be associated with hepatotoxicity, and the treatment for HCV is only for 3 months. So it's better to defer the TPT and first complete the HCV treatment in such cases. But INH does not have interaction with the HCV drugs as such. So in case if there is if there is risk of developing TB, a patient is in contact of the TB patient, in those cases, if you really want to prioritize the TPT initiation in such cases, it can be done and INH can be used. But then preferably, I would say that you can defer the TPT initiation till the HCV treatment is completed. Rifampicin 300, 1 tablet twice, or we really had a detailed discussion on this. So the dosage is basically what you need to remember about 1 HP is the dosage. So what you need to give to the patient is 600 milligram of rifampicin and 300 milligram of isoniazid. So whatever combinations you have, based on that, you have to decide whether if you have 300 milligram tablet and no FDC, then you might have to give 2 tablets. If you have FDC, which is 300 milligram rifampicin plus 300 milligram of INH, with that, you might have to add only 1 tablet of rifampicin. So please, you can go back and have a look into that slide again, and please use it as a ready reckoner. And whatever supplies you are getting, please, based on that supply, beforehand you decide that how many tablets of each drug you would be giving to your patients. Do HIV exposed children, exposed child also eligible for TPT if mother is TB patient? Yes, but then you have to reliably exclude TB in such exposed children, and it's always advisable to refer the exposed child for a proper evaluation by a pediatrician or a specialist. And if there are no signs or symptoms suggestive of TB, in those cases, TPT is advisable. Should all pill, that is ART and TPT, be taken at the same time? So basically, I think we discussed this with the it might be good to maintain some distance or some time interval between ART and TPT. Basically, when you are giving INH, it is preferable to give it empty stomach. When you are giving 1 HP, it is preferable to give after a meal. And for the ART, because ART is a lifelong treatment, so for ART patient would, and you want to maintain the same time and continuity. So for ART, it is advisable to please discuss with the patient that what time is the most preferred time for taking ART for this patient. And you can advise. So it's not that you have to club everything together. Based on the drug profiles and based on the preference of the patient to take what time he prefers to take ART, you can decide this. Is HIV exposed child also eligible for TPT if mother is TP patient? I think we discussed this. It is not better to give 6H2 IDUs rather than give 1 HP, modify dose and methadone, etc. So this is the question of basically because I think with ART we know the adherence of the IDUs is really poor, and from the centers we have closely worked with the centers which have a lot of PLHIV who are injecting drug users, and in those we really find that the adherence to ART as well as the continuation of IPT or 6 months of INH was very low. And that's why, because this is the question of how do you want to balance the things? So 1 HP is just a monthly course, and it's easy to to have a focused attention on IDU and just complete the 1 month's course. So, but then you have to, you can weigh in your scenario, but if you can work closely with your OST doctor, 1 HP, I mean, I would say that 1 HP would be a preferred regimen for the IDUs.
Ma'am, we have questions in the chat box. Can patients who have not completed 6H TPT regimen in the past due to side effects or poor adherence or LFU be restarted on 1 HP?
Yes, if people have not completed the INH course in past, so that means they didn't get a one-time course for TPT, and they can be given now 1 HP.
Ma'am, should we quickly run the compiled questions?
I think I have addressed most of the things, but we can open for the questions if there are other questions.
Yeah, I'll just take it from the chat box for now. We have many patients who are chronic alcoholic and used to drink regularly, and even after counseling, they are not ready to withdraw. In that case, can we give TPT?
See, with the chronic alcoholism, there are basically 2 issues. One is the issue of hepatitis or the deranged liver functions. The second issue is if you want to use INH, because it might add to the peripheral neuropathy. So that's why you need to be a bit cautious. It's not an absolute contraindication that you don't have to use or don't have to give TPT in PLHIV who are on alcohol. They can be given, but just ensure that they take their regimen properly and just evaluate before initiating them on TPT, evaluate them for liver functions, for sure.
Kadnikar, madam, not clear about your question. If you can please repost it again. Can ART and TPT be started simultaneously?
Yes, I think I discussed this in great detail, that it has an added advantage in terms of averting the risk for TB and as well as mortality. So we really want to give the benefit of TPT as soon as possible to all the PLHIV. So it's always advisable to start ART and TPT at the same time, but after excluding active TB.
If a patient has taken ATT twice, is he eligible for TPT?
So this was actually the earlier guideline that after completion of ATT, soon after that, TPT needs to be given to adults as well. But since now in the program, we are using a very robust ART regimen, and our PLHIV are virally suppressed. The immune response is really good. And that's why And there were like logistic issues because in all the trainings, these questions were coming up that it's very difficult to ask the patient to start a TPT course soon after completing the ATT treatment. So that's why this guidance was reconsidered, and this recommendation is not being made now that you start TPT soon after completing the ATT.
Next question, when to start TPT for TB, HIV co-infected patients?
For the co-infected patients, you need to treat them for TB. You don't have to start them on TPT. For TPT, your patient should not be having TB disease. So co-infected patient means that they have active TB disease and you want to first treat that.
If a patient is a defaulter of 6 HP, then restart TPT is new regimen 1 HP or continue 6 HP?
It perhaps like these patients might have discontinued 6 months of INH because of the prolonged treatment or pill burden or some of the toxicity. So one TPT regimen might be well tolerated and you can start 1 HP regimen now.
Once started on a particular regimen, shall we have to complete with that, or we can change based on clinical situation and supply?
So a proper evaluation initially is needed. And based on that, you need to start the TPT regimen. Obviously, there would be, to this rule, there would be exclusion where a person might get exposed to a DRTB patient. So in that's the only case where you might want to reconsider your regimen. But otherwise, the rule is that whenever you are starting a patient on a specific TPT regimen, please do a proper evaluation before initiating, establish the criteria and identify that which regimen the patient is eligible for, and then only you start and then you continue with the same regimen.
Can we give 1 HP with NRTIs?
We are not using NRTIs in the program now. But efavirenz is it can be used. So some patients might get efavirenz. With nevirapine you cannot use, but with efavirenz 1 HP can be used.
Without ruling TB as it is difficult in PLHIV with no symptoms, can it produce monoresistant TB?
I think there are ample studies to say that TPT does not cause resistance. And we really have a good experience of using INH prophylaxis for 6 months, for almost 8 years in the program now. So I don't think we have come across such cases. So whatever evidence we have as of now, that is in favor of using TPT and preventing the incidence of TB among PLHIV and reducing the mortality among PLHIV. So and the documented risk for drug-resistant TB are not that strong that one should not use TPT among PLHIV.
Is secondary TPT recommended in children after completing ATT?
Yes. For the children, because obviously children, the immune response is comparatively low, and even in terms of the viral load suppression, there are issues with the children. So TRG took this conscious decision that for the children, we would still use the secondary prophylaxis after completing the ATT.
For a HIV exposed child who is not registered at a ART center, how can TPT be given to that child?
This guidance would be coming to you more clearly. The revised guidelines for EVTHs are, I think they have been finalized and would be issued to the ARTs, I mean, to the SACs and ART centers very soon. So you will have more guidance. But at least if you're not taking care of the exposed kids, that's fine. But if you're taking care of the reactive kids, because if somebody is reactive and less than 1 year, would be enrolled with your ART center. So please do consider for that. And also for the exposed child, this is something like, no, because the mother would be with you. So if mother during pregnancy is having TB, So that's where I think you can actually want to advise her that when the child is born, because you are anyways required to do the prescription for the infant prophylaxis. In the same continuation, you can even say that since the mother is TB positive, it might be good to evaluate the child properly for TB, and if TB is not if the child does not have any signs and symptoms for TB, then TPT may be considered. And that note on the green book can be sent. So whenever the patient is going for delivery and discussing with the pediatrician, at least this information flows.
Ma'am, can I continue with the questions?
Yes, please.
Yeah. If a patient has already taken TPT in the past and is now exposed to DRTB, will that patient be eligible for 6-levofloxacin?
Yes, because it's a new exposure and it's the exposure to the DRTB. So it would be good to consider such patients for the TPT for DRTB.
We usually give 15 days ART while initiating. So can we initiate TPT in the second visit?
I didn't want to get into this, but ideally the national guidelines say that you should be giving the ART for 1 month during the first visit. If you still want to be in contact with your patient, you can even make phone calls or so it's a very specific issue to your center because it's not as per the guidelines. But if your patients are coming to you, if they are from a nearby place, and if you are not, the only thing is if you are sure that the patient does not have TB disease, it's good to start TPT at the earliest. But if you are in a doubt, then you can wait for some time and you can start ART first. And if there is TB, there would be unmasking of the symptoms, and then you can take a decision after 15 days. But that's only the case when you are in doubt. Otherwise, I think as a general rule, if you have excluded TB disease, in those cases, you should be starting your patients as early as possible on TPT.
PLHIV on 6H and LFU, can we restart 1 HP or 3 HP after re-engaging?
Sorry, can you repeat that?
PLHIV on 6H and LFU, can we start 1 HP or 3 HP after re-engaging?
Yeah, so that means they did not completed their their previous course. They didn't get a TPT course, actually. So you can start them now.
Or TPT has to be given only once in a lifetime.
Shweta, I think we have a hand raised from the Central TB Division.
Yeah.
Let's give them the chance first.
Sure. Ma'am, you can please unmute. Dr. Veena ma'am or Dr. Sanjay sir.
Yeah, so this is Dr. Hardik. I'm a national consultant for TB prevention. I have actually comment regarding the few of the clarification which has already been given by Dr. Reshu, particularly 2 points. One was repeatedly being asked about the ruling out of active TB. Right, so ruling out of active TB is very, very important. Not just a couple of times, but almost half a dozen of times. Dr. Reshu madam has very categorically said that the ruling out of active TB is important before initiation of a TPT. One of the question was there that if we are not able to rule out active TB, which is difficult, I would say it is not difficult. Madam has already presented a slide. When you appropriately do the symptom screening, the sensitivity of algorithm through the ruling out of active TB is more than 85% and negative predictive value is more than 98%. Through which we are almost 85% sure. Now, as I know that all the ART center before initiation of the ART as well as in routine follow pre-treatment evaluation, we are conducting the X-ray. So X-ray is a wonderful screening tool. When you do the symptom screening appropriately coupled with the chest X-ray, we are so sure that we are appropriately ruling out of active TB. And obviously, the absolute kind of a wording coming from the examiner, means treating doctor. So ruling out of active TB is very, very important before initiation, and we are very much confident that it is absolutely possible. We already have evidences and we are following the evidence-based medicine. Second is, multiple times we are asking that we previously have a TPT course, if it is LFU or if it is a missed dose or if it is in between interruption, not completed the previous course, we can restart, reinitiate the TPT. Now we have a shorter TPT regimen, we'll prefer the shorter TPT regimen. So that two part I just would like to stress upon at this moment. And over to Dr. Reshu.
Thank you, Dr. Hardik.
Ma'am, I'll continue the questions. Should TPT be given only once in lifetime?
Yes, the current recommendation is to use it once in the lifetime. Usually the studies shows that the efficacy of TPT in PLHIV is around 5 to 8 years, 9 years. But currently the guidelines say that the TPT course has to be given once in lifetime.
Previously treated MDR patients should be given any TPT?
No.
After completing ATT, are we supposed to give TPT? And if yes, then after how many days of completion of ATT?
So this recommendation is true for the children. So for children, after completing the ATT, they need to be provided appropriate TPT regimen. For adults, this recommendation has been withdrawn. But you really want to monitor these patients properly for any post-treatment TB as well.
If completed 1 HP course one time, then we need to again start TPT course after 1 or 2 years, or how long is the TPT effective?
I think I answered this.
Okay, ma'am. Okay, in a CLHIV having contact with DRTB, we have not given any TPT as per the earlier guidelines. Some children had contact with DRTB 4 to 5 years back. Do we give them tablet livoxin or can they be started on tablet INH? What is the time frame to say contact with DRTB?
So usually it is a recent contact and which is defined by CTD as a time period of 3 months. So if the contact has happened within 3 months and if it is a significant contact, that's how it is defined. It's a household contact, or even in a workplace, if there is a continuous contact with a DRTB patient. But then in terms of the timelines, the contact should have been within 3 months.
With isoniazid, pyridoxine is given to all the patients. Is there any indication?
It's to protect them or prevent the neuropathy. So it's always advisable to give pyridoxine with INH. And as I said, if it is not available, that does not mean that you do not give TPT to the patients. And you can even use some multivitamins or the B complex formulations.
For PLHIV on dialysis on nephrotoxicity, can the revised TPT regimens be provided?
Yes, I think we discussed this.
Done. These are the questions from the chat box, ma'am. Due to shortage of time, do you want to give mic access, ma'am?
We can give a quick mic access if.
So here again, Hardik, there is a last question on PLHIV on dialysis and nephrotoxicity. So just I would like to mention that the TPT drugs, which is isoniazid and rifampicin, both are excreted through the liver and not through the kidney. So underlying renal cause, we no need to modify the dose or no need to change the regimen. Thank you.
Thank you for the guidance, sir. Praveen sir, can we give quick mic access to everyone?
Yes, it is already given.
Yes, thank you. ARD Plus Center has raised her hand. Any questions, sir?
Madam, good afternoon, madam. My name is Dr. C. Anandrao, madam.
Good afternoon, sir.
Madam, we are in Vijayawada, the trainer of trainings meeting. We interacted with Dr. Reshu about providing IPT to people who have finished the ATT, even though they have previously had IPT, madam. We at that time, madam told us that she will refer to this and come and tell us about it. Is it once in a lifetime, or is it given every time a patient finishes ATT? That was the question then we raised. And madam said, and I also forgot about it now because I'm seeing madam, I wanted to ask this question, madam. I hope I made myself understood.
Sir. So the first thing is that the TPT course is once in lifetime. It is not to be repeated. That is one. Secondly, for the PLHIV who successfully complete their anti-TB treatment, in such cases, because most of the studies which recommended that we should use a TPT regimen after completion of the ATT were done in the pre-ART time when people were not being given ART. So, and that's how that recommendation was there. But now, since our PLHIV are like, no, all one is we have treat-all, so all PLHIV are all getting ART. Secondly, we are using very robust ART regimen, which really help in ensuring the immune reconstitution of the patient as well as the viral load suppression. And the PLHIV are like, no, almost living a similar life as the non-PLHIV right now. So that's why, and there were like, because centers like you actually raise the logistic issues also, that it's very difficult to continue the patients on TPT after completion of the ATT. So this was discussed in the TRG, and the decision was taken that we will, for now, we will not make any such recommendation. And in fact, NACO and CTT have together, like, no, they are still trying to understand the sort of the quantum or the bulk of what is the problem statement for the post-treatment TB. So we really don't have, currently we don't have answer, like, no, among PLHIV, when does the post-treatment TB happens, and when should a TPT course be given after completion of the TB treatment. This is something which needs a proper study, and I would request the centers like you and the medical officers like you, and the COEs are also here, ART plus centers are also here. Please look into your data and see, like, no, when do your patients who complete their TB treatment, when, and if they are getting a repeat TB episode or a recurrent TB episode, when are they getting that? That would actually help program to have a more definite guidelines that what is the appropriate timing for giving a TPT course for the PLHIV who complete ATT.
Good afternoon, madam. Good
Sir,
afternoon.
good afternoon.
Good afternoon, sir.
Ma'am, I am Senior Medical Officer Dr. B.N. Tripathi from Bhubaneswar. My
Yes.
question is, we have today, just today, we have received supply of INH and this rifampicin combination, which consists of 300 milligram of INH and rifampicin 300 milligram. But the extra 300 milligram of rifampicin is not supplied, probably it is not available. So can we give this to our patients for the same period, or we can extend the period?
The period has to remain the same, but you can't extend the period. But then you need to focus on the dosages. So the dose is 600 milligram of rifampicin plus 300 milligram of isoniazid. And if you have that dose, then only you start your patient. If you don't have that dose, please discuss with your counterpart at the DTO or the STO and get the additional supply for rifampicin.
Okay, thank you.
But ensure that you have 600 milligram of rifampicin plus 300 milligram of INH to give to your patients. That is non-negotiable.
Because in the actual presentation, in one slide, I have seen that there is 3 months of SP. There is one mention somewhere in the slide in the beginning, I think.
That was a question I asked, like, no, because so 3 months of HP is also a regimen for TPT, but under the national program for PLHIV, we did not adopt it.
Oh, okay, thank you.
So 3 HP is not a regimen for PLHIV. For PLHIV, it is 1 month of rifampicin plus isoniazid. The dosage is 600 rifampicin plus 300 INH. And for all the ART centers, I'm repeating this again, please ensure that you have the appropriate drugs and then you start your patients.
Okay, thank you, madam.
Madam, one more question, madam, please. This is the last question.
Ji, sir.
Madam, see, some of the times what happens is who come for TB treatment, they don't know that they are positive. They come for TB treatment, and because they are everybody by mandatory, we have to test for HIV. Some of them turn out to be HIV positive. So we put them on ATT as well as ART. For such patients, what about the TPT guidelines, madam, for such patients?
For such patients, you can use TPT for such patients.
After the ATT?
Yeah. But then you can see what would be the appropriate timing for such patients to start.
That is what I wanted to ask,
madam. Ideally, you can start after giving a gap of 3 months or 6 months. That's where you can start. But that's why I said, sir, I think as a national program, we don't have much data available with us on the post-treatment TB.
Okay.
And so that's where we need to understand when does this post-TB happen, so that decision for the right timing for TPT can be taken.
Okay, right, madam. Thank you very much.
Vinoda ma'am, would you like to come in? Any more questions? Participants can unmute or they can put their questions in the chat box. Ma'am, we have one question in the chat box. What regimen is to be given to contact of previously treated MDR patient? You're on mute, ma'am.
I didn't get the question clearly. Perhaps if somebody has been treated for MDR,
yes,
then that person is treated actually. And if somebody is contact, then the contact is defined as within 3 months the exposure should have happened.
Any more questions from the participants?
Just one question. Thanks for a nice presentation, Dr. Reshu. The question was basically, if you see the dosages that you have given milligram per kg body weight, they are quite high for children, it seems, higher than adults.
Sir, the dosages for most of the TPT regimen in children are comparatively higher because of the higher BMI in children.
Okay, thank you.
Hello, ma'am.
Yes, Dr. Pooja.
As per now, after completing ATT, we are not starting TPT.
Yes.
Thank you, ma'am.
I think we will have a discussion with NACO on understanding the post-TB thing and give you a more clear guideline.
Thank you, ma'am.
Any more questions? Please feel free to unmute.
Ma'am, can I say something?
Yes, Dr. Hetal, please.
Ma'am, previously we did not give TPT to patients who were contacts of DRTB, right?
Yes.
So those patients are till date, they are without TPT. Should we give them now?
No, actually, it's very difficult to assess the index case thing. So and as we were discussing, when we are talking in the context of DRTB, that the exposure should have happened within 3 months. And so somebody, because see, you have to see the entire arena of the things. Because your patients are on ART, they are adherent to ART, they are responding well to ART, they are virally suppressed. They are in terms of their CD4 counts, if they are good, and they are actually not developing TB. So that means with the entire spectrum of things, we are able to protect TB in these patients.
Okay.
Right. So maybe what happened 3-4 years back, that means now patient has got that immunity.
Okay.
And is not developing TB. But again, Dr. Hetal, as I said, I think we will see into a multicentric kind of a thing, in terms of the post-treatment TB and the progression of the TB, when is it really happening and when are the patients baking into TB.
Okay, ma'am.
Thank you.
Okay.
Dr. Lalit, may I add a point?
Yes. Dr.
Yeah,
Hardik?
thank you, ma'am. Thank you for the nice presentation, ma'am. Just to add a point on the context of DRTB, the index case should be FQ sensitive. Then only it can be given. So this is an important point with respect to the context of a DRTB case. And in that scenario, we'll have to take care of that. Thank you.
Thank you.
Dr. Vinoda ma'am, would you like to come in? Ma'am, I don't think there are any more questions. Can we conclude the session now?
Yeah, sure.
Shweta, we can,
Yes.
this Dr. Purnima, Dr.
Yes,
Chinmoyee
ma'am.
just left for another pre-scheduled meeting. We can also check with CTD team if they have any more comments to add. And
Sure,
then
ma'am.
we can conclude if there are none.
Sure, ma'am. Dr. Hardik, sir?
No, we don't have any further comment or deliberation. It was an excellent deliberation and opportunity provided by the team, entire team NACO. I must congratulate team NACO, specifically Dr. Reshu madam, for a wonderful presentation, and also here Dr. Veena madam and Dr. Mattoo sir for guiding the team from the Central TP division. Dr. Veena madam has also gone for another meeting. We can, with this brief remark, we can kind of sending back to you over to Dr. Sweta.
Thank you, sir. Purnima ma'am, any closing remarks from your end?
Thank you, Shweta. I would like to extend my gratitude towards Dr. Reshu for the wonderful session, and to Dr. Veena ma'am, Dr. Chinmoyee ma'am, and all the CTD team, Dr. Hardik for coordination. And thank you very much for this session. And I'm sure there were so many questions. It was such an interactive session. So I'm sure going forward also, if there are any questions, states will get back to us, and SACs and ART centers would work in coordination with the state TB teams and district TB officers for a more streamlined approach in implementing the new regimen. So that's all from my side. Thank you very much.
Thank you so much, ma'am. We thank Dr. Chinmoyee ma'am, Dr. Veena ma'am, Dr. Sanjay sir, and Dr. Reshu ma'am for their continuous guidance and support. We thank Dr. Purnima ma'am, Dr. Hardik sir, and Dr. Lalit sir for their guidance and support. Thank you, Dr. Evari sir, for joining us for today's session. Thank you to all the ART centers who have sent in the questions and queries on TPT. That was a great help. Thank you to all the participants for